Hi, I'm Anthony Nasser. I'm a sports physiotherapist with a keen interest in proximal hamstring tendinopathies. I'm currently working as a lecturer at the University of Technology in Sydney, and I'm currently completing my PhD through La Trobe University on proximal hamstring tendon injuries. Today I'm going to be walking you through some of my research with Brad on the Physical Performance podcast.
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to episode 321 of the Physical Performance Show, brought to you by Polar's brand new Polar Pacer and Polar Pacer Pro running watches, the world's top choice in personal guidance for fitness, sports, and health. I'm Brad Beer, sports and exercise physiotherapist by trade and training and founder of Pogo Physio. Each week, we'll bring you the latest and greatest information and inspiration designed to help you perform at your physical best. Of course, we do this across a range of our different episodes, featured performers, interest editions, coaches' corners, learn-ins catch-up episodes, and of course, our ever-popular expert editions. And hot off the back of last week's expert edition with core body temperature sensors technology lead Chris Blumfield-Brown, who shared around thermoregulation in sports, we're keeping the learnings rolling this week with PhD candidate and APA sports and exercise titled physiotherapist Anthony Nasser. And Anthony will share today around the diagnosis, management and prevention of proximal hamstring tendinopathy. Now, this is such a common running and triathlon related injury. It presents as pain around the sit-in bone and unfortunately can be quite recalcitrant to get on top of. As a sports physiotherapist myself, working with runners and triathletes, it is one of the most common injuries that I personally deal with in the consultation room. And today's expert, Anthony Nasser, along with his team of colleagues, recently published a great scientific paper titled Proximal Hamstring Tendinopathy, Expert Physiotherapist's Perspectives on Diagnosis, Management and Prevention. A wonderful resource to help clinicians and athletes alike navigate this tricky condition. Now, by way of bio, Anthony Nasser is a sports and exercise physiotherapist and lecturer at the Graduate School of Health, Discipline of Physiotherapy at University of Technology, Sydney. Anthony graduated with a Bachelor of Applied Science, Physiotherapy from the University of Sydney and a Clinical Masters of Physiotherapy in the field of sports from the University of Queensland. Anthony has worked extensively as a clinician in musculoskeletal and sports physiotherapy and is now a titled APA sports physiotherapist. He has considerable experience teaching musculoskeletal physiotherapy across multiple universities. So get set with your pen and paper. Here is my conversation with Anthony Nasser, sports physiotherapist, exploring proximal hamstring tendinopathy, diagnosis, management, and prevention. Anthony Nasser, I've been looking forward to this conversation for quite a while. You've been a busy gentleman in the final stages of submitting your PhD, but welcome to the Physical Performance Show.
Thanks, Brad, and thanks for having me on and allowing me to share my research with you today.
Well, let's talk about the topic of your research, proximal hamstring tendinopathy, which for any running-related athlete, triathlete, endurance runner, and practitioners, most people know of someone that has had an episode of proximal hamstring tendinopathy, or PHT as it's often abbreviated. Why your interest, Anthony, in this, particularly for a PhD that you've dedicated many years to thus far?
This is an injury that I guess I got interested in it as a physiotherapist. So I started working as a physiotherapist around 2009, and I was seeing a lot of AFL athletes and also runners, and I guess getting the outcomes that I'd hoped for. Around this time in about 2011, 2012, there was a really important publication that came out in the British Journal of Sports Medicine, and it talked about how the importance of managing compression in tendinopathy. through that, I learnt a little bit more, and on the back of that, I started my sports masters in 2014. And through there, I guess I started to engage a bit more with researchers focused mainly on hip injuries. And I was seeing a lot of patients with proximal hamstring tendinopathy. We started to get, I felt like, pretty encouraging outcomes. And at the same time, I was working as a tutor at the University of Queensland. I guess I got involved in research through that.
You're in the field clinically, seeing patients, you're engaging with researchers, you're doing your sports physiotherapy masters. It seems like a fairly obvious path that this might occur. And the clinical world is very appreciative that it has occurred, because your paper is was published in 2021 in Physical Therapy and Sport. I found it very easy to digest with some great teaching points. But what was the design and how did this paper come together?
This paper came together on the back of another study that we published. So we published a systematic review which looked at, how effective different treatments are at managing the condition. So we published that, I think, in 2020. That was looking at, all different types of interventions and how effective they were in managing proximal hamstring tendinopathy. So we looked at the literature, and we noticed that, interestingly, that the literature was biased on, I guess, more invasive procedures like injection therapies such as platelet-rich plasma injections or corticosteroid injections, and surgery. There was actually very, very little research on, traditional rehabilitation, which is, been proven to be quite successful in other tendinopathies. So on the back of that, we thought, well, what's the best way to understand what current best practice is? And we thought that the best way to do that was to, engage and discuss in detail with different, physiotherapists from around the world, and ask them, well, what do you do in terms of assessment and management and prevention of the condition? And the best way to do that was a qualitative design, which involved interviewing, quite detailed interviews, in fact, with experts from around the world on, all those things.
And the expertise of the experts, they were, I think the average years of experience was 24. So these aren't your typical graduating therapists. These are very well seasoned, credentialed, experienced practitioners.
Yeah, exactly. So we wanted to make sure that we really understood, well, what really is best practice. And we wanted to make sure that the experts were from a variety of different, locations around the world. And they also worked in a variety of different sports. We were actually really happy with the experts that we recruited in the end.
I'm sure they're all willing to share, because it's great to get some sort of commonality on approaches as clinicians, particularly when it comes to best practice. So, Anthony, let's explore the key subsections of the paper, starting with diagnosis of this condition first. And your paper breaks it down into subjective, or the history of the condition, and then looking at clinical tests. So let's start with the history, the subjective history. What are some of the common themes that emerge from the experts around how they best detected or best took histories for this condition?
Yeah, so a really good history, I think, as along with your clinical tests, are kind of the key ways that experts diagnose tendinopathy. So traditionally in the research, I guess we've relied on imaging and palpation in determining our diagnosis. However, in this case, we saw that, I guess, the major things that therapists look for in the history were location of pain. And so in terms of location of pain, that's well-localised pain around the ischial tuberosity that doesn't really shift and spread too much. In terms of onset, the typical onset tends to be insidious. So athletes will tell you that, their symptoms started in the hours after, they've done, a physical bout of activity, or the morning after. So there shouldn't really be a clear mechanism of injury. So it's more insidious in onset as opposed to traumatic. It typically occurs on the background of a spike of, a real increase in training load. So particularly an increase in activities that involve, as you'd expect, really high hamstring load, and in particular high hamstring load that involves positions of hip flexion, where we think you get that compression against the ischial tuberosity.
And such positions, examples of that, and for the listener that may not be familiar with the term hip flexion, bringing the knee up to the chest, I guess, in that position. What activities can that constitute, Anthony?
Well, in runners, it's typically hill running is really common. In cyclists, it might be, doing hill repeats, sitting in the saddle, where, you are really putting a lot more load through that area. It might just be performing a little bit more interval training as well. And so more speed sessions will place a lot more load through the hamstring and hamstring tendon. The other big thing that patients have problems with is sitting as well, that I wanted to say. And so that's a huge aggravating factor. And that's probably one of the primary things that patients are often concerned about, because we spend so much of our life sitting, whether it be, for work or, relaxing after work on the couch.
Anthony, on the report of a change in workload, from your own clinical experience working with footballers and runners, what sort of changes in workload? Obviously, we could think about increase in time spent running up hills, speed work, which increases that angle at the hip. Anything else that you'd sort of alert people to just to keep their feelers out for? Yeah,
any increase, like you said, in training volume or intensity. It could be the introduction of a new drill that involves, high hamstring load, and in those positions that we discussed with your hip a little bit more flexed. Or it might simply be, the introduction of different activities in the gym setting. So maybe, they're performing a few different exercises, maybe deadlifts from the floor, or maybe some deeper squats or some incline leg press that really do expose the hamstring to, I guess, high compressive loads.
Excellent. And I don't think we can overstate the importance of a good clinical history in helping us with our diagnosis. You shared some great tips there via the expert's contribution. That shifting or spreading, if that's reported, Anthony, would you agree the clinicians have to have their antenna up for the possibility that it may not be localized hamstring tendon issues?
Yeah, definitely. So if the pain's spreading down the leg or shifting with exercise, or the patient's not exactly sure where their pain is, or it changes from week to week, it's probably worth thinking that, it might not be hamstring tendinopathy, it might be something else.
And then the clinical tests, which are one of the other mainstays of diagnosis, the experts all agreed that they performed as your paper states, a battery of clinical tests using progressive load-based mechanisms. Can you explain what that looks like to the everyday listener? This load tolerance increase in demand with the testing?
Some clinicians use special tests that have been, reported on in the literature. And so the idea of these tests are simply to reproduce your buttock pain. Like I said earlier, and when we're discussing the clinical history, the pain tends to be very well localized. And what we do like to see in patients with hamstring tendinopathy is that there is a graded increase in pain with increased load. So when you're doing, lower load hamstring provocation tests, and an example might be a single leg bridge in minimal hip flexion, 45 degrees, we're going to expect to see, minimal pain or symptoms typically, and you're going to see the patient's symptoms increase as we increase either hamstring load and or compressive load by placing them in more and more hip flexion. And so that's something that we do like to see. So other examples that experts used, activities like an arabesque or a drooping bird. And then there are a few different tests that have been looked at in the literature as well.
And those three passive tests there, can you describe those visually? What do they involve?
The first test is it's termed the Puranan-Arava test. And it involves a patient, placing their leg up on a plinth or a bed and touching their toes. So it's very much a passive hamstring stretch, basically, and you're looking for pain over the ischial tuberosity, so that well-localized pain we were discussing earlier. And then there is the bent knee stretch test and the modified bent knee stretch test. Well, the bent knee stretch test is where the patient's just lying on a plinth, and then the therapist is just slowly bringing their ankle up into a hamstring stretch type position. And the modified bent knee stretch test is where that's just done a little bit more vigorously. So there's a little bit more load going through the hamstring tendon. So those tests were used by some clinicians. There was a thought by some experts that patients with, I guess, a more mild hamstring tendinopathy, that sometimes these tests aren't sensitive enough. So patients might not be positive with some of these tests. So that's probably worth keeping in the back of your mind.
And the classic single leg bridge test, any tips that you'd give from your acquired knowledge there, Anthony, to the practitioners in the field on how to make sure that's done well and progressively to increase the demands?
I mean, if you're trying to reproduce a patient's pain, I think that test is an excellent test to reproduce a patient's pain. So making sure that you are in adequate hip flexion, I think is key. So making sure that you're in, I'd say at least 90 degrees hip flexion. And then it can become more provocative if obviously the knee's a bit more extended, so the patient's hamstrings are on a little bit more stretched. So generally that test is enough to reproduce a patient's pain. With a lot of patients, coming to the diagnosis can be quite simple. There are times where it can be difficult. Usually we're able to come to a diagnosis just based on the history and combining a few of these clinical tests.
Brilliant. Palpation, Anthony, which for those aren't aware, that's obviously poking around the area that's symptomatic. What were the experts' top teachings here around palpation? Palpation
of this area is quite difficult because you've got the big gluteus maximus which sits on top of the area. So experts had, I guess, different views on the importance of palpation. So palpation has traditionally been used as, I guess, one of the key clinical tests in diagnosing tendinopathy. But, over time, I guess we've moved away from palpation a little bit. We had a group of experts who said that palpation really wasn't important, and they found that, sometimes patients present and they're, poking around the area and they're unable to reproduce a patient's pain, but they were still quite sure that they had proximal hamstring tendinopathy. But then we had another group of experts who thought that palpation was really important, and that a reason why therapists often couldn't reproduce patients' pain was that they weren't palpating the entire footprint of the hamstring. So a lot of experts thought it was particularly important to palpate the lateral portion of the ischial tuberosity, where semimembranosus attaches, which is thought to be, I guess, primarily involved in the injury, which is one of the hamstring muscles, I should say.
Palpating that attachment more laterally was something that I picked up from reading the paper as well.
Yeah.
Anthony, the experts seemingly concurred that as part of the exam, this is the assessment we're still talking about here, they screened patients for contributing factors that they believe might be relevant to the development of the condition. Can you just touch on some of these potential contributory factors that experts screened for?
That was a key theme. So not only did experts want to establish a diagnosis, but they wanted to figure out, well, why has the injury occurred, and whether there's any contributing factors. So it might be looking at things simply like an athlete's technique. So it might be their running technique. And I think we'll talk about biomechanics a little bit later. It could also be things like past injuries. So it might be that the patient's had maybe a knee injury, which has changed the way they move. So it could be something like an anterior cruciate ligament injury. Or, we see patients with following knee replacements with hamstring tendinopathy sometimes as well, or any other injury that might limit their movement at the ankle and knee and then make them move a little bit more at the hip.
Yeah, it makes sense. And capacity tests that the experts performed, can you just share around what regions were tested and why that's important?
Regions that came up time and time again were the calves and the glutes as well. So notwithstanding the hamstrings, of course. So the areas that clinicians, I guess, really thought could contribute to the area were the calves, the hamstrings, and then the glute max They were also very interested in movement control around the hip. So having a look at, the single leg squat performance in a dynamic fashion, having a look from, front on from the side and making sure that the patient had, sufficient control for, I guess, the activity that they needed to perform was considered to be really important by all experts.
An example of the assessment of the calf could be a calf endurance test, single leg raises to fatigue with good form.
Yeah, exactly.
Anthony, the experts also, as you say, considered as part of the consideration for contributing factors the biomechanics of the athlete. So in the instance of runners with proximal hamstring tendinopathy, what features of the gait were they interested in?
Having a look at an athlete and how they run. So typically most experts would have a look at how a patient would run on a treadmill in clinic and have a look at their running gait in slow motion. And things that they're typically looking for are things that might place increased load through that region. In particular, those things are running with a lower cadence and potentially overstriding as well. So a large heel strike out in front of your body with a low cadence we think might put more load through the hamstring, as well as maybe running with a more, where the athlete's falling into a bit more of that anterior pelvic tilt. That was another factor. Another one was that was mentioned by a few experts was if an athlete is sitting a bit lower when they run, so maybe they're running in a little bit more hip flexion. And, clinically, I think that we might often see that if a patient has got, maybe concurrent hip joint pathology and they're a bit worried about moving into, I guess, as much hip extension when they're running. Yeah,
which I think many listeners will be able to get a picture in their mind's eye of what that running athlete could look like. But some really great considerations there for contributory factors. What were the expert opinions around the use of imaging in the diagnosis of proximal hamstring tendinopathy?
The diagnosis of tendinopathy is very much a clinical diagnosis. And so it's based on findings in your clinical examination as well as your patient interview, so the history. So imaging doesn't play much of a role at all in terms of diagnosing proximal hamstring tendinopathy. However, it can be useful in terms of differential diagnosis. It also doesn't really help us as an outcome measure or help us, I guess, gain an insight on the prognosis. So it doesn't help us tell an athlete how long they're going to take to get better or whether they're improving. So it actually doesn't have too much of a use here outside of differential diagnosis.
It's such a great point you raise. Its prognostic abilities are quite limited in that most clinicians will acknowledge that we can image most athletic people and likely see some sort of change at that proximal hamstring tendon region, right?
Yeah, that's definitely the case. So when we look here, a lot of the findings, I think that when we image, I think one study looked at 500 patients and they found that over 60% had changes in their proximal hamstring tendon region on imaging. But that was in patients with an average age of about 60. When we look at younger people, there isn't too much evidence, but there was one study that looked at athletes with a mean age of 30 and about 25% had, I guess, changes in that region on MRI. So it probably is a little bit less in younger populations. However, that might not be the case in athletes who do put a lot of load through that region in sport.
Anthony, I recently had that area of my body imaged via an MRI and MR and showed that I had some decent tendon change there, but I've fortunately been asymptomatic, not in any pain there for always. So it's a good little example. The experts did mention that if the patient or the athlete is unresponsive to management, and this is obviously a big topic in that it's got to be the correct management applied over the right period of time, but then they might revert to imaging to query other potential masquerading conditions.
Yeah, definitely. If you're giving your patient a nice loading program and you're adhering to management and the patient's not improving at all, I think it's worthwhile either getting a second opinion or sending them for imaging to confirm your diagnosis.
If nothing else comes of it, it's just reassurance that we're on the right page and we need to keep keep progressing with these known principles and adhering to them. Differential diagnosis, Anthony, or in other words, conditions that need to also be considered in that area. What were the experts' sort of key differential diagnoses that they were considering when assessing the patient in front of them?
Yeah, it really is a long list of potential diagnoses that experts need to consider in a patient presenting with, pain around that area. We can break it up. So typically we might think of, what areas can refer to that region. And we're thinking, typically the lumbar spine, sacroiliac joint and the hip joint typically. However, their pain tends to be a little bit less localised. So it tends to be potentially a little bit more vague and shift around and spread if it's referred from a joint. And the symptoms tend to be a little bit less specific to hamstring loads in positions of hip flexion. Then, we're looking at peripheral nerve entrapments as well. So your sciatic nerve was a key consideration by all experts, I guess, as a potential differential diagnosis, as it travels so close to the proximal hamstring tendon insertion at the ischial tuberosity. So I think anatomical studies show it's only about 1.5 to 2 centimetres away from the proximal hamstring insertion. So that was another consideration, as well as particularly in the case of more traumatic injuries, looking at injuries like hamstring ruptures or other injuries to, the hamstring. You can have stretch-type injuries to the semimembranosus, which also tend to occur quite proximally, as well as in, younger athletes. I think there's other considerations that we need to think about as well. So we can see injuries that affect more of the apophyseal attachment. So these injuries do tend to present in quite a similar fashion, but in younger athletes, and we treat them slightly differently.
As you say, the younger athlete, we need to consider those potential scenarios. And in the running athlete, I'm yet to see one in 15 years of clinical practice, Anthony, but I guess it could come. Stress fractures of the ischial tuberosity as well.
Yeah, that's another consideration as well. Stress fractures to the pubis or the ischial tuberosity definitely are another consideration that we really don't want to miss.
And the experts did mention that we also need to give consideration to systemic inflammatory conditions such as ankylosing spondylitis and psoriatic arthritis.
Yeah. So your alarm bells might start to ring if a patient's also reporting concurrent, stiffness in their hip joints and their lumbar spine, particularly, morning stiffness that lasts for, more than 30 minutes. Then we might think about, a secondary referral, maybe some blood tests as well, and some further imaging to see if we think that a patient does have more of an inflammatory arthritic condition, which can, of course, occur concurrently with the condition.
And once again, good call to arms for a good, thorough history when assessing the athlete in front of us, talking about any stiffness that's latent, etc. So, Anthony, that's brilliant on the assessment front. Obviously, we move into a big topic, and your paper sequentially walks through this around management of these conditions, managing proximal hamstring tendinopathy. In general terms, your paper states that the primary management options were education and exercise, but then it also talks about passive intervention. So if you're happy to, we'll walk through these systematically here. Education, what can that comprise? What were some of the experts' key themes here?
So education, I guess, is really important, and all experts spend a lot of time educating patients about the condition and what to expect. So up front, patients want to know about the condition and the prognosis. So I think it's critical to set up patient expectations. So making sure that patients understand that this condition isn't something that goes away overnight, and that symptoms, often persist for, 6 months to a year. That's with rehabilitation. That's not if you just let it go. So patients need to understand from the get-go that this condition does hang around for a while, and that, it does require, significant rehabilitation in order to have a really good outcome. However, I don't think it's all doom and gloom. We do have good results with patients who adhere to their rehabilitation as well. I think it's really important also to teach patients, about a bit about tendinopathy and how it responds. So telling patients and telling them their tendon really talks to them. So if a patient has symptoms the day, increased symptoms the day after, a bout of exercise or something, then they've often done a little bit too much. It's a good idea to teach patients and tell them that, pain doesn't always necessarily mean harm. It's often that, if they have an increase in symptoms, that they've just done a little bit too much, and we've just got to back off a little bit and get, the amount of load that they're putting through the tendon right. Other things that are worth talking about is, what it's going to take to get better. And so I always tell them that, we do need to do some special exercises, that target the hamstring tendon and the areas around the injury. And we need to do that for, a good 3 to 6 months. And that, that it's important to, load the tendon and keep it and healthy for life as well.
Gosh, so much there. It's also rich in so important education, the role of it, talking to the athlete, the patient around what to expect, the prognosis, tendinopathies and how they behave, load tolerance, pain doesn't equal harm or damage necessarily, and that this will take time, 3 to 6 months of adherence, often beyond that in instances. And the 24-hour sort of sign and anything you'd add to that, the expert shared and you also have picked up from your own clinical experience over the years, Anthony?
It might just be in your rehab exercises or when you're reintroducing an athlete to a bit of running. If they do have symptoms that increase in the hours following, the following morning, it's probably just a sign that, we put a bit more load through the tendon than it's happy to handle. So it just tells us that, that we need to, I guess you really want to have a chat to the patient and really understand what they've done and then try and modify things slightly and until you make sure that, their symptoms aren't, worsening too much. We're not looking for the symptoms to completely, disappear. We don't expect you to wake up and have no symptoms, but we're just making sure that, the patient doesn't have a flare up. So sometimes, if you do a little bit too much, so it might be you go out for a bit of a longer run and then, and you have a bit of a flare up, it can last, for, often, it can last for days, but sometimes even a couple of weeks. And it can really set us back in our rehab. So I guess making sure that our rehab and I guess the patient understands that their tendon really will kind of talk to them and dictate how quickly, we can progress through the rehab.
And your fellow sports physiotherapist, Melbourne colleague, researcher, Latrobe colleague, Ebony Rio had shared that great little adage, we're looking for low and stable symptoms. Yep. Yeah, it's such a nice adage, isn't it? Anthony, the paper cites one of the experts that commented, I think empowering people and giving them like really positive sort of self-efficacy and not only reassuring them that they'll get better, but giving them the tools to get there is important. I think it really captures it, right?
Definitely.
Exercise. So this is the second mainstay of effective management of proximal hamstring tendinopathies. You've broken it down into targeted hamstring rehabilitation and then kinetic chain rehabilitation. On the targeted hamstring rehabilitation, Anthony, what are some of the key considerations here to make sure this is effective? There
are a few things that we need to consider. And in the early stages and the mid stages of rehab for proximal hamstring tendinopathy, we need to make sure that the exercise that we're choosing does put a considerable amount of load through the hamstrings. An example where maybe a clinician might go wrong would be if they're performing a bridge exercise for the hamstring with their heel close to their bottom and the athlete's able to use their glute max to perform the exercise. We really need to load the hamstring and put some good healthy load through the tendon. So you really want to make sure that the exercise that you've selected does place adequate load through the hamstring. The second and really important factor is to make sure that the exercise you've selected doesn't put the patient into too much hip flexion. That makes a really big difference as well. So it might be just selecting an exercise like a prone hamstring curl instead of a seated hamstring curl that can make all the difference. The other thing is that we want patients to perform the exercises nice and slowly. And so, making sure that they're thinking about, getting some good time under tension for the hamstrings. So performing, nice slow repetitions rather than racing through their hamstring exercises. So I think with your hamstring loading, you can't go wrong with prone hamstring curls. I think that they're a great exercise for this condition. And the final thing I'd like to add, would be making sure that the patient is putting adequate load through their hamstrings. So, if the patient can get themselves to the gym, I think that really helps us out as physios, so they can put some, good solid weight through their hamstrings in order to develop adequate strength. So, that makes a difference, I think.
I'm pleased you said getting to the gym can really make the therapist's job a lot easier. It sure can. Dr. Peter Maliaris, must be something about the Melbourne research scene with tendons. It's so strong. He's formerly shared around clinical benchmarks of circa 0.3 to 0.4 times the athlete or the patient's body weight single leg hamstring curl has been a bit of a range for a target. Do you yourself clinically use any sort of clinical benchmarks, or did the experts share around that at all, Anthony?
Nothing too specifically, to be honest. I think, there's a bit of research that we shouldn't use the strength of their opposite limb as really a guide, as that, often can be weak as well. And so, but, in saying that clinically, I think most physios and most of the physios I spoke to during this study do use the opposite limb as a bit of a benchmark initially, and then try and improve the strength up to, 90% of their asymptomatic side. However, in the long term, we shouldn't really be looking at that alone as really a benchmark.
So you could go beyond that, as you say, in the long term. Kinetic Chain Rehabilitation, maybe just a quick explanation of what the Kinetic Chain is and what that means. What did the experts mean here, Anthony?
We want to think about, how can we ensure that there's less load going through the hamstrings when performing a particular activity? So what muscles can we really, really improve in order to reduce the load through that vulnerable region? So in particular, experts spoke about the glute max, which is a synergist. So, it's also a hip extensor like the hamstrings as well, your lower glute max. So making sure that you do some good rehabilitation of the glutes, as well as the calf as well in particular, making sure that you're doing, like you spoke about earlier, those single leg calf raises, maybe some seated leg calf raises as well. And the good thing about that is you can often get some good load through the glutes and calves early in your rehabilitation if you're selecting exercises that don't involve too much hip flexion and hamstring load early in the piece.
Yeah, brilliant. And the paper does talk in this section about addressing movement retraining for aberrant biomechanics, which we've already touched on. You've shared there around as well. One of the sections here is mid to late stage exercise management. Any key tips for this stage of rehabilitation that the expert shared? So we're not talking about the early stage, settling it all down, assuming that's been done. What do we need to remember for this mid to late stage rehab phase?
Yeah, so I think with the first stage, the early stage and the mid stage, we always want to select an exercise for each of those streams that you just spoke about. So you want your high hamstring tendon loading exercise, you want your kinetic chain exercises going, and you also want to be doing some exercises where you're working on maybe movement control as well. So I think it's really important in your mid and late stage management to continue that and to continue exercises where you're working through progressing exercises in each of those streams. So I think one of the key considerations is to keep your strength training going. So in the mid stage, we're looking at making sure that we're really getting the athletes to work quite hard in the gym. So you want to make sure that they're, really putting in and making sure that they're working towards, that 6 to 8 RM for 3 to 4 sets. So making sure that the athlete's choosing 2 different hamstring exercises, maybe one across the knee and one across the hip, and making sure that they're really working within those kind of strength guidelines to really improve their hamstring and the strength. It's also a good idea to keep your kinetic chain training going and really, again, focusing on your glutes and your calf in particular. That it might be any other region where, the athlete might have an area that's a bit prone to atrophy. Maybe they've had a previous knee injury and they're prone to a bit of quadricep atrophy, and making sure that while they're going to the gym that they're also addressing any other related deficits as well. At the same time, at the mid and late stage, we're able to start with our functional exercises anyway that don't have too much hamstring load, start working into a little bit more hip flexion range of motion. So it might be that you choose an exercise like a small step up or a slower sled push or something if you've got that type of kit in your gym. And you're able to start to work into a little bit more hip flexion, but in activities that don't load the hamstrings, I think, too much initially.
You used a word that I think is so important. I know clinically I cannot overstate this word enough when trying to educate patients through the process, and that was the progressive word. These exercises need to be progressive.
Exactly. And so we need to, often it's difficult to get to the gym with an athlete, but ensuring, I think, that they're working hard enough. So, we can use things like maybe an RPE scale to make sure that the patients are working really hard, and making sure that they're really fatigued through the hamstring, can't do another rep type of thing. So I think it's kind of empowering for athletes once they're able to work really hard. And I think they feel really good about their hamstrings once they're starting to get strong again.
Passive interventions, we've discussed, or you've shared there, Anthony, education and exercise, the two mainstays.
Yeah.
As you mentioned at the start, when you did the literature review, there's a lot of literature, or a bias towards literature focused on passive interventions, corticosteroid injections, PRP, platelet-rich plasma injections, surgical interventions. What did the experts concur around the use of passive interventions?
They all agreed that they had a very limited role in the management of proximal hamstring tendinopathy. So no expert really referred any patient for injection therapies like you've just spoken about. So that's your PRP or your corticosteroid injections. The mainstay of treatment was, as you said, your exercise and your education. So manual therapy didn't have much of a role in the management of this condition, which is kind of good for patients, I think. They're in control of the condition, and it's about, going through the rehab and really just committing to it, I think.
Yeah, going through the rehab and committing to it. And no doubt at times feeling a little frustrated along the way.
That's it. It's very easy for me to say that. But, and it's definitely, you're going to need to expect that there's going to be, you're going to stir the condition up a little bit along the way. I guess trying to trust in the process and usually, we can come out with a pretty good outcome, I think.
You're listening to Anthony Nasser, APA titled Sports and Exercise Physiotherapist, on this expert edition exploring proximal hamstring tendinopathy. Support for today's show comes from Polar, the world's top choice in personal guidance for fitness, sports and health. Polar are extremely excited as they've just launched two stunning new generation running watches, the Polar Pacer and the Polar Pacer Pro. These new running watches will give both first-time runners and serious runners the tools and the insights to track their performance and inform training. Both watches offer an incomparable running experience with powerful training and recovery features that help runners understand their body and know when they're doing too much or not enough to reach their goals. Engineered specifically for running, the Polar Pacer and Polar Pacer Pro are equipped with a variety of functions unique to Polar and provide personalised guidance and support across the entire runner's journey, from the first steps to the marathon and beyond. The Polar Pacer Pro is for those who want to run better. It's one of the most powerful and sophisticated running watches ever built. It's ultra-light with a high-performance core processor and includes an extensive suite of advanced training tools that will help serious runners improve their running economy and performance. It has built-in navigation and running power, and it's debuting at an incredible $499. And the Polar Pacer, well, it's for those who want to fall in love with running. It's an ideal watch for those who are starting their journey as runners, embodying the simplicity of running with all the essentials, plus the specialised training, sleep and recovery tools that they'll need to fall in love with the sport. The Polar Pacer will help all runners get started at $299. So if you feel like it's time to beat your best, jump across to shop Polar at polar.com. Support for today's show also comes from Earshots. Lock on, train on and rock on with Earshots Bluetooth headphones. Earshots have you covered for staying motivated while you train. earShot's magnetic ear clip means you can push your limits without being distracted by annoying cords or earbuds that fall out. Use the code PERFORMANCE over at earshots.com for 10% off your purchase. I can vouch for the earShots Bluetooth headphones. They accompany me on my long runs and rides, and we're thrilled to have earShots partner with us. For now, let's jump back with Anthony Nasser, APA titled Sports and Exercise Physiotherapist, exploring the management, treatment and prevention of proximal hamstring tendinopathy. Return to sport. We're talking about the management of the condition here still. Returning to sport, one expert cited, it is pretty rare that we stop someone altogether. So what were some of the main themes around return to sport here, Anthony, for successful proximal hamstring tendinopathy rehabilitation?
Yeah, it's good that you brought that up. We see athletes particularly, and I'll just reiterate that a lot of the experts I did interview were involved with elite sport. And elite athletes do often have a good foundation, a strength foundation. And so, a lot of clubs these days obviously have strength and conditioning professionals who are working with athletes. And so these athletes often, they all spend time in the gym. They've got a higher baseline of hamstring strength, I think. And maybe this enables them to continue performing their sport, even despite, having a hamstring strain injury. However, we always do, in the cases of, when a patient does have proximal hamstring tendinopathy, do need to reduce the amount of load that's going through the tendon. And I will say that in the sports that we're talking about here, we're probably talking about sports like AFL, field-based sports, as opposed to maybe purely running-based sports. And I'd imagine in an athlete who is a sprinter, they might struggle more to perform in high levels of pain or a hurdler.
But in general terms, finding that, as Craig Purdom would sort of say, that happy workload is important as opposed to sitting on the couch where possible.
Yeah, definitely. And so we know that, long-term rest. So rest can be really, really helpful for the tendon in the early stages from, high load activities. But it also, in the long term is going to be very detrimental. We want to limit it as much as we can in terms of, how long we take an athlete away from high tendon load activities. And that really varies from, patient to patient.
And on that high tendon load concept, something I picked up from your colleague there, Ebony Ree, over the years was that education to the rehabilitating patient or athlete that the gym work is not high load on the tendon. They often fear that it'll flare them up, but the flare-up will come with the high loads associated with energy storage activities, right? Like fast running uphill, or sitting for a prolonged period of time.
Yeah, that's it, isn't it? So typically the exercises, where there's minimal hamstring compression, so performed in minimal hip flexion, are really provocative. So your hamstring curls and things like that. And they're really safe to perform, like you said. It's activities like running where you're putting high loads through the tendon and asking the tendon to store and release energy that, often are more provocative.
We're still on rehabilitation before we jump over to prevention here, Anthony. Monitoring, many clinicians will know of the Victorian Institute of Sport Proximal Hamstring Tendon Questionnaire. Most agreed that it wasn't used a lot. But what were experts using to monitor it? Subjective report, overall functionality, anything that popped out?
There are a few things. So I think looking at, things like strength was really important. So I think all experts like to monitor knee flexion strength. And so whether that be, just talking to an athlete and asking them how much weight they're moving at the gym and seeing that is gradually improving. It might be, seeing how much pain they have during, a consistent exercise or, an activity that's meaningful to them. It might be simply looking at how much pain they have doing like an arabesque every morning to see if they're improving there. I think that's, really important, making sure that that what you're monitoring is important to the patient and they can basically see that they're improving. I guess questionnaires aren't really used or meant to be used on a day-to-day basis like the visa. And those specific questionnaires might be used every 6 weeks or so.
Yeah, brilliant. But that daily monitoring that can be done by the patient athlete is so key. Prognosis, Anthony, I enjoyed this little section of the paper around the fact that it can take over a year at times and that there can be obviously recurrences. What are the key themes from the experts' opinions on prognosis?
I think, addressing it, like we said, so patients understand it right from the start that this is a condition that takes a long time to get better. So we're saying, 6 months to a year. And so it's really not unusual at all for patients to have ongoing sitting pain beyond a year. And I know that, that's probably not great news for a lot of patients listening, but it doesn't mean that their function hasn't improved along the way. So, I think that the key focus that we try and have throughout the rehab process is making sure that we're following function rather than, just looking at things like sitting pain. The sitting pain does improve in time. However, that's often the last thing to go.
Yeah. That's rich. Certainly been a clinical observation of mine over the years, Anthony. And then the final section of the paper around prevention or preventing recurrence. What were some of the key themes here? What advice has emerged?
So the big thing was maintaining strength. If a patient can continue to get to the gym, ideally a couple times, but maybe once a week to the gym and maintain some good hamstring loading, was key. So, just making sure that the patient gets down to the gym, does their, set of prone hamstring curls or a few sets of prone hamstring curls to maintain some good hamstring strength, I think is really important, as well as some good strength through the kinetic chain. The other important thing was maintaining, a consistent workload. So making sure that you don't suddenly increase the amount of, loading that you're doing is the other big thing that we look for in prevention. There's not actually a lot of research to base a lot of this information on in terms of, reducing recurrence of tendinopathy. A lot of it's based more on clinical experience.
I've certainly observed when people stop the strength work, either volitionally or just due to life circumstances, that can open the door for a recurrence, if you like. So some great advice there. I did smile, actually laughed when I read that one of the experts stated it along the lines of just need to make sure that the patient continues strength forever, basically.
Yeah, I don't like saying that to patients, but I do believe that if they really did want to make sure that it put the odds in their favour, that'd be the best way to go about it.
Anthony, thank you for walking us through some of the key emergent themes from the paper. Every guest of the show gets issued with 2 set questions each week. And the first is, if you could boil everything from your knowledge accrued over the years to date, clinically, academically, research to date, into maybe we keep it centered on this theme of managing proximal hamstring tendinopathy, what would Anthony Nasser's key piece of advice be, maybe to the practitioner first, and then we separate it out to the athlete or patient recovering from the condition?
In terms of advice to practitioners, so I think that we progress patients too early into exercises that involve large amounts of hip flexion. So I think we're often really keen to progress patients back to, exercises like your deadlifts, deeper squats in the gym, even the, incline leg press. And I think a lot of these exercises really stir patients up. So I think we're probably better off focusing on return to sport rather than worrying about, pushing patients back into these exercises before they're, doing the activities that they really want to do again.
There is some pressure to feel like you need to progress people, but sometimes there's a discipline to not progress for the sake of it, right?
Definitely. I think we're always really keen to get patients back to doing things that maybe they used to do, or us just wanting to get patients back to, performing exercises through their kind of normal range of motion. But I think if we can just put the brakes on that and get patients back to, running or the sport that they enjoy, I think we need to prioritise that as a profession more than chucking in exercises because we feel we need to.
And top piece of advice, Anthony, for the athlete or the patient?
I think you've already said it earlier in the podcast. I think if you can get to the gym, if you've got proximal hamstring tendinopathy, find yourself a gym where there's a prone hamstring curl machine. That'll do wonders for the condition. So unfortunately, a lot of the gyms these days have gone a little bit more functional and they seem to have fewer and fewer machines. But if you can find one with a nice prone hamstring curl machine, my best advice would be to use that a few times a week, and it will really help get this injury under control.
Gosh, I'm so pleased you mentioned that. It can be a bit of a search for a prone hamstring curl machine. It's not quite as sexy as the squat rack these days in a lot of gyms.
It's not, is it? The monkey bars and the squat racks.
Yes, it's the new norm. Anthony, every guest, in this case, expert edition guest, yourself, issues a physical challenge for the week. So what is your physical challenge to the listeners going to be for the week?
Well, if you're in Sydney like me, the rain's been coming down all week. So I reckon it's been pretty hard for me to get out for a run. So maybe get an extra session at the gym. I think a lot of us spend a lot of time performing lunges and squats, targeting our quads and our glutes, but we often neglect our hamstrings and our calves as well. So since we're talking about hamstrings today, an exercise I love working towards in early stage and mid-stage management is a single leg biased hamstring bridge on your heels in about, so you're lying on the ground and your knees bent only a small amount, so say about 20 degrees of knee bend, and trying to work up towards a minute hold for a few sets with good form. If you want to give that a go for your hamstrings, I think that'd be a good one to give you a bit of a workout for those hamstrings.
We'll call it the Anthony Nasser hamstring hold challenge. It's pretty brutal, Anthony, but let's all have a go at it. And if we do take it on, we should let you know. And you're readily found over on Twitter at Tony Nasser, NASSERPT, capital PT. Where else can the listener engage with you, Anthony, and your work?
That's probably the best way to find me. I also work as a lecturer at the University of Technology. So my email and contact details are all online. All the research that we're publishing through La Trobe University, where I'm working as well and completing my PhD, we're talking about earlier, can be found online through, a link to the website as well.
And we'll connect all those, Anthony, in the show notes over at physicalperformanceshow.com. Thank you for your generous sharings today. All the best with the final stages of the PhD submission. And thank you for your contribution to the field, both for athletes and practitioners. It's an important one around such a common injury that isn't always managed well. So outstanding work. Thanks, Anthony.
Thanks again, Brad, and thanks for inviting me on and allowing me to talk about, my research, which I'm really passionate about.
It's a great job. Thank you, Anthony. So there you have it, another episode of The Physical Performance Show, and I trust and I know that you enjoyed Anthony's sharings today. You'll find Anthony over on Twitter at Tony Nasser PT, NASSERPT. Do reach out and let Anthony know what it was that you enjoyed or took from his sharings today. And of course, take on that great physical challenge and tag Anthony in at Tony Nasser PT on Twitter, and of course the show on Instagram at Physical Performance Show. Keep the training podsies coming. That's a screenshot of the episode that you're enjoying. Tag us in on social and we will reshare those. They are always a whole lot of fun. A massive thanks to our show patrons for your support. If you'd like to support production of the show, you can do so by jumping over to physicalperformanceshow.com, clicking on Patreon, and there you can become a show patron from just $5 per month, supporting the production of the show, and in return will grant you complimentary access to our back catalogue of live stream events and all upcoming live stream events. A massive thanks to this week's new show patrons, Jared Balnavs and Ewan Connolly. Gentlemen, thank you for your support of the show. Massive thanks also to the great folk who make this show possible each and every week. Daryl Misson, audio engineering, Susan Wilkin, show administration, Matthew Olding, show graphic design. And if you're battling with proximal hamstring tendinopathy and frustrated with not getting to where you need to get to, Pogo Physio offer online telehealth consultations. Simply jump over to pogophysio.com.au. It can be a very effective platform for helping you get back to your best with pesky conditions such as proximal hamstring tendinopathy. We'd love to help. Now, coming up on next week's episode of The Physical Performance Show, we're jumping over onto two wheels with Team Ineos Grenadier professional cyclist Pavel Sivakov. Pavel will share his career highs, lows and learnings, and there's plenty of them. So be sure to be tuning in next week. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been The Physical Performance Show.